latest, there are a group of doctors calling themselves the Universal Healthcare Access Coalition, believing that they have an alternative route to what he describes as the unfeasible National Health Insurance Scheme. Months after the President had signed into law the NHI Act, the coalition has unveiled the reform framework, which it says will address South Africa's critical healthcare challenges. It says this framework outlines practical solutions to improve access, equity and the quality of the country's healthcare system while ensuring financial stability. Dr. Simon Strachan is a member of the steering committee of the Universal Healthcare Access Coalition. Dr. Simon, good morning and welcome.
Very good morning to you. Thanks for having me and good morning to your listeners.
What is this committee and how did it come to be?
So the coalition was formed in response to the President's call for anybody to bring a reasonable proposal on how to achieve health reform. And we decided to get the three big organizations, the Progressive Health Forum, South African Private Practitioners Forum and South African Medical Association, and the Radiological Society. The four of us got together, the leadership, and decided that we should put together a proposal of how we saw healthcare reform being effectively managed in this country. So it was really in response to the President's call, and we then put together a proposal, and we've been that was presented to the President in December. This was after we met with a whole lot of various healthcare representative organizations and had 26 different signatories. We've now got 29 signatories on this. We had 50 organizations in the room, and we are still opening the door and saying anybody who'd like to comment on this is welcome to comment across the board. We're creating a platform for engagement. And we started by sending it to the President, and that was then sent on to the Department of Health. And when we followed up on that recently, we were told that it's being perused, but no comment because this is all sub judice. Sub judice, I presume, because of the legal action against the NHI, but this is not about the NHI, this is about health reform. But be that as it may, that is where we are standing at the moment.
Okay, and so how does this model, the work that you guys have done, differ from what is the current understanding in the way that NHI will work?
So the proposal we've put on the table is based on and built on research recommendations that have been developed since 1998 and were actually part of national policy until about 2007 when the NHI came into being. So we were building on the current system and we're building on recommendations, not least of which is the recommendations of the Health Market Inquiry. So what we are saying is that you need a funding model that is not tax-based. If you try and have a tax-based funding model in South Africa at the moment, when we are already at the tax ceiling, meaning any further increase in personal or business taxation is actually going to result in less tax being collected. So it is impossible to drive things through a tax-based model. So you need a funding model then that is affordable. That's the first thing you need. And the second thing you need is you need a system that is going to ensure that there is equity in access of healthcare. And remember the goal here. The goal is universal health coverage, which means people will be able to access healthcare at the least financial hardship from well-resourced, well-stocked, well-run institutions. So the proposal looks at the population as we have at the moment and go, what do we have? Well, on the financing side, we have people who can afford to contribute, and we have people who can't afford to contribute. If you are not employed and you can't afford, then you fall under government healthcare. If you have a job, you then should be mandated to pay towards your healthcare. But this is smoothed over by a national subsidy, which is directed more to the poorer people. So you try and smooth over the costs. People can move between public and private. If you're in the private sector, on a fund, on a scheme, whether it's our suggestion of a public-sponsored scheme or one of the well-known medical schemes at the moment, you can seek care in a government hospital, and your private practitioner should be able to deliver the service in the public hospital. But what it needs rejigging of the private sector. We need to bring in the Health Market Inquiry recommendations. We need to bring in risk equalization. We need to, in other words, bring in models that are going to stop the massive rising healthcare costs and give the private healthcare medical schemes the opportunity to rethink and to not have these massive increases so that private healthcare becomes more and more affordable. And you do that by mandating medical aid cover so that younger, healthier people come in, contribute to a system, understanding that the older you get, the sicker you get. And at the end of the day, when you retire and you don't have an income, that's when you need the help. And the public sector needs to be properly governed. We need to take out political influence in the public sector. We need to ensure that every hospital, every clinic down to district level, building a district health system, is run autonomously by by boards appointed with people who are able to do the jobs with independent oversight, no political interference, where the CEO is accountable to the board who is appointed, and the hospital board and the CEO are accountable to the community in which they work. And essentially, that's how you devolve and you decentralize it. So procurement and service delivery will be decentralized down to the provincial and regional levels, whereas the NHI is bringing everything centrally, controlling everything from the top, doing away with provincial health departments. So that's really what this is about. It's about a different funding model, and it's about regulating private healthcare so that the service is affordable, sustainable, and most importantly, it's scalable. It can be increased as we go along. And in doing that, we believe you will get equity of access to healthcare.
Okay. The way in which the NHI has been packaged, at least in its public relations, was that if I don't feel well, I can go to a GP of my choice, or that's within that sort of a radius from where I live. The GP then can make a referral if I do require additional treatment, and if I do require, for instance, a procedure to be done, that whether it's done by Mediclinic or whether it's done by my local day hospital, that wherever it is, I would be able to gain access to the type of care that I so do require. In terms of the methodological approach here for the public, how would the proposal that you're putting on the table, how would that work? I would assume that if you're saying that those that do still have private medical aid, but that has certain reforms to it, that they would be able to benefit from it. But the sort of subsidy that's being provided here, to whom exactly is that subsidy provided? Is it going to fix public health care? And as you say, with the district boards and, getting a proper board in place and that sort of thing. But where do I go if I need proper health care, and where will my cover be covered if I can't afford it?
In your first example around the NHI, when a system is just completely unimplementable because there is just not enough money to implement the system the way that it's suggested, it means there won't be a system. And I think that we just can leave that where it is now. So what we're proposing at the moment is the strategic framework of how a health system could run effectively. At the nuts and bolts level, obviously that will be determined. And the idea is that it's determined as far as possible by the province and the region and the district where the health system is required. So the primary healthcare delivery within that area would definitely be delivered by clinics and by GPs. And the idea in the model is that you would be able to go to the GP of your choice in the area where you work. If you are belonging to the contributory system, if you do not have a job, then there will be in time an effective public health system that will offer clinics and offer primary health care. So you will have equitable health care across public and private sectors, and you'll be able to access in the public and private space a basic package of care that would be decided for both systems. But you would have the capacity as an individual to make the choice. If you are unemployed and you are under the state sector, you will access your care from the state. If you're employed, you are therefore contributing and you're being assisted by the national subsidy. You can access healthcare from the nearest health facility that you have, whether it's public or private. And if you access it in the public sector, the public clinic, hospital will bill your medical aid, and the medical aid will pay for it. The one critical thing that we've also put in this proposal is a national policy for emergency care. So this is what's important, is if you are accessing healthcare for the day-to-day winter coughs and colds and those things that come up often, and we all deal with them, well, then you can make your decisions. But if you're in an accident, well, you sometimes aren't able to make that choice. There has to be a system where if you fall down on the side of the road for whatever reason, that the nearest ambulance picks you up and takes you to the nearest hospital, and that's the end of the story.
Yeah.
Good healthcare, it gets paid. We have to have a national strategy for that. You may have heard many times people say the national health systems in other countries, they're only designed to look after the very sick, and they have emergency responses, because that's the right thing to do. If somebody collapses on the street in the middle of Cape Town while walking along the seafront, you need an emergency care person there within minutes to defibrillate them and to resuscitate them. And that's part of what we're doing here. So
Yeah,
really are looking at patients. Yeah.
And we don't have a lot of time, but I was wanting to look at how you think from in a rural setting this could work, because I think the sort of peri-urban areas is a little bit complicated, in terms of the way NHI contemplates that. But in the way NHI contemplates the rollout of universal access to healthcare from a rural setting, for me, makes an incredible amount of sense. I look, for instance, at and in fact, I spent some time in the Eastern Cape sometime last year, and there were scenarios where if somebody gets sick and if the ambulance finally arrives, it's a question about do we take you to a public health institution, or do you need to be driven to Kaberga to get private access to health care, and that sometimes can be a life and death situation. And so there are different scenarios in different circumstances, as you also highlight the role of perhaps provinces and different provincial boards to be able to determine what best works for them. So I think it's a conversation that requires a lot more expanded time to understand. And let's pick it up on another time. But thank you so very much for sharing some of the basics with us, Dr. Simon Strachan, a member of the steering committee of the Universal Access to Healthcare Coalition.